Bismillahirrahmanirrahim. Assalamu alaikum. Dear colleagues, we are discussing hepatitis B, and when we discuss these 6 case histories, then we started to review all the guidelines, pertinent features, in an attempt to understand that our aim is that of the prevention of the development of liver cirrhosis and its complications, with the two goals that we should be able to know when to start treatment and when to stop treatment, and then to achieve these objectives, the goals, we are now discussing the main important components of this whole workshop. Yesterday, we discussed the HBV life cycle and its clinical implications. Today, we shall discuss when a patient is present to us with the HBs antigen being positive, what workup is important, and what is the role of HBe antigen in the management of chronic hepatitis B. So, as I said before, the workup prior to treatment and role of HBe antigen is our topic today. When a patient presents to us with a HBs antigen positive, we should do two important tests. One is to see if the patient has got co-infection with anti-HCV or anti-HDV in our setup in Pakistan. This is very, very important that we should check the HCV antibodies and hepatitis D antibodies to see if this is pure HBs antigen mono infection or there's a co-infection. And when we do these two tests and these are negative, the tests which are done regarding the HBs antigen being positive, we can divide these into three main groups. One is to do the virological profile or viral profile. Second is to see or check for the liver status. And third is to look for the general health status of the patient. So we can divide our workup prior to treatment into three main classes or groups or categories. Number one, viral profile. Number two, liver status. And number three, general status. In the viral profile, what we do the HBe antigen and anti-HBe. And this tells us whether our patient is HBe antigen positive or HBe antigen negative. If a patient is HBe antigen positive in chronic hepatitis, this may be HBe antigen positive infection or hepatitis. Previously, these were called immune tolerant phase and immune reactive phase, respectively. And if the HBe antigen negative, the patient may be in the HBe antigen negative infection or hepatitis. Previously, these were called immune control phase and immune escape phase, relatively. Then the second test is to know the viral load. This is very, very important to know the viral load because there are set viral loads when we will be discussing the treatment, the indications to start treatment. This is very important then to know the viral load because if the viral load is not reaching the threshold to start treatment, then we observe these patients and over time, and when the viral load increases from that threshold, reaches that threshold, then we start treatment. And if a patient, of course, is on treatment, then of course the viral load also matters. And the third investigation is, of course, the serum bilirubin and ALT, anti-HBC IgM in total to see whether this is acute hepatitis or chronic hepatitis. So these are the different components of the viral profile of the patients when a patient presents to us with the HBs antigen. What are the investigations for the liver status? Of course, clinical features of cirrhosis. If the patient has got clinical features of cirrhosis, like the patient has got splenomegaly or ascites, or patient has got a history of hepatic encephalopathy or upper GI bleed with maybe varicose bleed. These are the different clinical features of cirrhosis. And when these are present, then we label that HBV-related liver cirrhosis patient. But when these are absent, of course, the next investigation is abdominal ultrasound to see whether the liver is small, shrunken, or normal, what is the portal vein size, what is the spleen size, and whether ascites is present or not. And when the ultrasound is also normal, having normal liver, normal portal vein, normal spleen size, and mildly increased size, and no ascites, then of course the role comes that of the EPRI and FIB4 and fibroscan to see whether the patient is having a normal liver or cirrhotic liver, the fibrotic liver. And of course, it may be cirrhotic, compensated cirrhotic liver as well, F4, when the ultrasound is normal, but the EPRI and FIB4 and fibroscan tells us the patient has got F4 fibrosis. And of course, the next category of investigation workup is to see the general health, clinical features, chronic blood CBC, the liver function tests, and the other remaining components of the like PTINR, albumin, all those things, and of course the urea, creatinine, and RBS. Because we don't treat infection, we treat a patient, and for treating a patient, we must be clear in the whole scenario of this very patients. This is the EPRI and FIB4. These are the smartphone-based calculators, and you need for the AST to platelet ratio EPRI, the AST levels, the AST upper limit normal, and the platelet count, and it tells you the results. For fibrosis at a FIB4, you need the patient's age, AST, ALT, and platelet count, and it tells you. These are the different questions for you. A patient's age 35, patient number 1, ALT is 38, 24 is the AST, and 270,000 is the platelet count. This is another patient, another patient. So when you calculate these, the EPRI comes different, for depending upon what is the level of these patients. And of course, when you do the FIB4, again, it also depends upon what are the different levels of this very patients. When you put this idea, the value into your EPRI and FIB, it will give you the results of these. You can take the screenshot of this, and when you feed these data, it tells you what is the EPRI of this patient and FIB4 of this patient. A role of HBe antigen in the treatment of chronic hepatitis B. For treatment initiation, HBe antigen status really doesn't matter. This is important. Its role is if someone plans to stop treatment prior to HBs antigen seroconversion. In such cases, patients must have normal liver with F0 or maximum F1. HBe antigen positive hepatitis, previously termed as immune reactive phase. Before treatment, patient should be in this phase, and the treatment should have made PCR negative and HBe antigen seroconversion, and after achieving this, must have received 12 to 18 months of consolidation therapy, and there must have been no breakthrough in the HBV PCR. And of course, only then trial of no antiviral treatment may be given with close monitoring for the relapse. This is the role of the HBe antigen, the chronic hepatitis B patients. For example, this is the patients where the patient has got F0 or F1, E antigen positive, and this is the PCR has become negative. You give the antiviral treatment, no, there is E antigen seroconversion, and of course the ALT is normal, PCR is negative. You give the consolidation phase for 1 month to 18 months, and then you stop treatment and you continue. So this is the time duration: 0 and 3 months, 6 months, 9 months, 12 months, 15 months, 18 months, 21 months, 24 months. Here you give these patients consolidation phase, and then you follow up these patients. If it is non-cirrhotic liver with low level viremia, it means viral load less than 2000, then HBs antigen quantification come into play. And this is when there is more than 1000 treat, less than 1000 do not treat, and follow up these patients. By and large, chronic hepatitis B is a dynamic disease. Initiation of antiviral treatment must not be a knee-jerk reflex after seeing first results. If ambiguity exists, better to wait for 3 to 6 months and dust settles down when twilight fades away and situation becomes clear. But decisions are done mostly by tailoring method for each patient. In HBe antigen positive chronic hepatitis B with low viral load and raised ALT may be the last part of immune reactive phase, and viral proliferation is probably being controlled in natural way by patient's immunity, so I shall personally wait for it. Personally, if my patient is ready for lifelong treatment, then I shall start as authority lies with the patients. If not, then I shall wait for 3 to 6 months and see if PCR becomes negative and ALT normalizes by itself. Having said that, such patient does need close monitoring. So, dear colleagues, today we discussed that what should be the workup prior to starting these patients on treatment. And we said it's the virological profile, the liver status regarding the workup regarding the liver status, and workup regarding the general health status. And then we saw the role of the HBe antigen. By and large, there is no role of HBe antigen in starting the treatment. The role comes when you want to stop the patient treatment before the HBs antigen seroconversion. So, in the next video, we shall discuss that what's the ultimate aim of treating these patients, what is the philosophy behind treating these patients, and why we wait in few patients and we don't wait in other patients, what are the gray zone areas, and how to deal with patients presenting with the gray zone areas. Till then, take care. Goodbye. Khuda Hafiz.